Hello, everyone. I'm very glad today to be a moderator and joining Dr. Amr Safwat in this very fruitful and very hot topics about the ultrasound uses in critical care medicine. And as we know, ultrasound is widely used in ICU and in anesthesia field as well. It has an important role to identify any problem inside the ICU, help in diagnosis, contributing in therapeutic procedures, and the follow-up even the progress or regress of the disease. So everyone now is going to advocate that intensivists should have mandatory training about the program for basic, advanced, and expert level in using the ultrasound in critical care. Actually, it helps us in hemodynamics and the fluid status of the patient. It helps in lung problem, as we will know the cranial Doppler and checking the head and intracerebral edema, the abdominal sonar and checking the organs. The thrombotic and embolic events, even it can be diagnosed by the ultrasound. The ultrasound improving the diagnosis and outcome of all patients in critical care and in anesthesia even as well. Today we will have three sessions about, we will talk about the lung ultrasound and the echocardiography and the transcranial Doppler. We will start by Professor Dr. Santosh Kumar. Dr. Santosh is a professor and head of Department of Critical Care Medicine in Bhopal Fracture Hospital. He is BLS, ACLS, ATLS instructors, and he's the fundamental critical care medicine instructor. He's interested in the field of critical care and has completed the bachelor class of echocardiography from Medical University of Vienna. He's gonna talk about the echo-guided hemodynamic optimization. The floor is yours now, Dr. Kumar.
Good evening to all. It's about 10 in India, and hopefully it's 8 or 8:15 at Cairo. So
yes,
thank you for inviting me and letting me talk about echocardiography and its use in hemodynamic management. So without wasting much of time, I would come straight away to my objectives, which is I'll be talking a bit of basics of transthoracic echocardiography, indications, the several views which are of importance, and there will be some tips to optimize image. And in the end, I'll be just reviewing all the talked about things with 6 steps of hemodynamic assessment in very high risk patients, basically for anesthesiologist. So the first slide is about what we must know beforehand, before you do anything on echocardiography. We must know our limits, like what we are capable of. We must know the echo views, basically eyeballing assessment of LV function, a diagnostic for pericardial and pleural effusion if it is there, and assessment of volume. Talking about indications for echocardiography, in critically ill patients, we use as a stethoscope for volume assessment. It's vitally important for circulatory failure of any etiology, be it tamponade, left ventricular dysfunction, valvulopathy, or pulmonary embolism. And then using this as an hemodynamic tool for assessing and monitoring our patients. It's of vital importance in patients who is in respiratory distress, be it cardiogenic or non-cardiogenic pulmonary edema. And it has been utilized by various fraternity as a tool for weaning from a ventilator. We know that it's important for managing a thoracic trauma, chest pain, and cardiac arrest. But before we do, we need to prepare our patient. And preparation would be on the front of positioning. If it is possible, left lateral is the position of choice, but many a times it's not possible. Room should be quiet and dark. And the echocardiographer should use dominant hand for probing as a pencil or a pen. And the device must be in front of the echocardiographer, and gel must be applied to improve the contact with the patient and have a better view of what probe we are using. We should use phased array probe like this with a frequency between 3.5 to 5 Hertz. And the things to note is there is a marker and a notch. And whenever you are using this probe, use it as the image you are getting on the sonology machine. About transthoracic echocardiography, we need to have few basic vital measurements like chamber evaluation, valves, and pericardium. So coming to what views to start with, Plaque's view is parasternal long axis view, which you acquire. You can see the image out here, where to put the probe. It's at the parasternal area between 3rd to 5th intercostal space. And the notch on the probe must be directed towards 9 to 10 o'clock or towards the right shoulder. If you put the probe like this, probably you are going to get an image which something looks like this. You need to label all the structures what is seen out here and just match. This is RV, as you see here. This is interventricular septum. This is aorta, the aortic valves, the mitral valves, anterior leaflets and posterior leaflets, and bit of papillary muscles you could visualize. So if you could put the probe in right position and try to see it, probably you are going to get such images. And how to optimize this image. First, you need to be few things you need to take care. For example, the septa which you have seen must be as horizontal as possible. And apex of the left ventricle should not be visualized. You should see aortic and mitral valves, but not the tricuspid valve. So if you have such things in your image, you are probably done. But if you could not get such images, how to improve your acquisition? If you see tricuspid valve in Plaque's view, you just angle your probe upward and remove this tricuspid valve from the image. If you see the apex of the left ventricle, rotate your probe a few degrees clockwise so that you shouldn't see apex of left ventricle. And if you lose the image, come back closer to the sternum. You may be sliding on the chest. So these tips, if you take care, then the other view, which I would say one of the most important view, is apical 4-chamber view, where you should put your probe at the apex and the notch should be towards the left shoulder or 2 to 3 o'clock position. What you could see in apical 4-chamber view is all the 4 chambers of the heart with tricuspid and mitral valve opening and closing beautifully. So for labeling, this is left ventricle, right ventricle, right atria, tricuspid valve. This is left atrium and mitral valve. So if you probe the image you acquire, you need to label all the structures. Moving ahead, if you can't get a good image like this, then probably you have to troubleshoot in this fashion, where the crux or the interatrial and the interventricular septum, if it is tilted towards the right, then you need to translate your probe laterally. You are too medial. If the crux is tilted laterally, then you translate your probe medially. And if you can't see mitral and tricuspid valve, then you are probably looking down. Angle the probe up. If you don't see LV apex, then try to scan from 1 or 2 intercostal spaces lower. And if you get a big and round shaped right ventricle, then you are too medial and too high. You need to move lateral and down. So if you remember all these troubleshooting, then probably you will acquire a good image. The next view is a subcostal view, which is mostly utilized in a ventilated ICU critically ill patient, where you need to put your probe like this, 2 to 3 centimeters below the xiphisternum, probe towards left side and notch towards the left shoulder at 3 o'clock position. What you will get is an image like this, where you are actually using liver as a conduit, so you could start labeling. This is the liver, the heart with all the 4 chambers. This is right ventricle, right atria, tricuspid valve, left ventricle, mitral valve, left atria, interatrial septum, and diaphragm between the liver and the right side of the heart. How to get good subcostal view? As I mentioned, you start from 4 centimeters below xiphisternum, insinuate your probe towards the left side and the notch at the 3 o'clock position. Try to acquire an image. For example, if you couldn't do this in patients who has been operated, or there is something on dressings applied here, you could acquire the same image by moving down along the subcostal margin and making use of liver as an acoustic window. You can definitely move towards the mid-axillary line and acquire the same image. But remember, when you are doing so, try to increase the depth of the image to acquire good view. So in subcostal view, you could acquire inferior vena cava while entering into the right atrium, as you could see here. Utilizing all these views, you could manage hemodynamics of your patient and comment upon volume status. If the patient is having tamponade, and what is the right ventricular systolic pressure, you could definitely come to know, and cardiac output. So as we know, volume status, as we are knowing it, the Frank-Starling law, where the steepest part of the portion is where you could give fluid and get a good cardiac output in return. But many a times you could do the other way, where you could put heart under tremendous stress with fluid, and hence this tool, echocardiography, will come to help you. Because as you know, hemodynamics, when we talk of hemodynamics, the heart rate, the blood pressures and outputs are neither specific nor sensitive. And if you could acquire some data about the stroke volume or the ejection fraction, probably more than 15% of change with a fluid or passive leg raise test would tell you that person is fluid responsive and it is not going to harm. We know how to do it. Patient should be in recumbent position, 45-degree, and then you just do the head down with a 45-degree raised legs for 1 minute, and simultaneously you just compare the baseline VTI. VTI is velocity time integral. I'll come to that. And then measuring VTI again, looking at how they behave, whether there is positive change or not, and then taking your decisions. There are something which you could make out easily with the use of ultrasound probe. Severe hypovolemia, if it is present, for example, a bleeding patient, you could have all three things: collapsed chamber, collapsed IVC, and LVOT obstruction. So if you could make out all these, probably you are done with the management of hypovolemia. Coming to tamponade, as we know, tamponades we need to have presence of pericardial effusion, collapse of RV free wall in diastole. And when we look at the IVC, there is loss of IVC respiratory variation. And because of increased interventricular dependence, the interventricular septum is pushed towards other side. So you can easily even quantify and do the therapeutics under echo guidance. Moving on, a bit of theory. In pericardial effusion, if intrapericardial pressure rises above intracardiac pressure, then you see the thing in sequential fashion. Earlier, it is start with, it's an RA inversion in late diastole. And if the pressure goes up above RV pressure, then there would be RV collapse, end diastolic RV collapse, early diastolic RV collapse as well. So this is the physiological aspect of RA-RV collapse, which you could quite clearly visualize in this loop. You could make out, this is a 4-chamber view where you could see all the chambers and pericardial fluid, which is obstructing the filling of heart. As we know, there is increased ventricular interdependence. And because of that, for a person who is spontaneously breathing, what you could see is with inspiration, there is decrease in mitral valve inflow and increase in tricuspid valve inflow. Whereas if the patient is on positive pressure ventilation, this would be the reverse. What you see in expiration is actually what you see in inspiration in reverse fashion. Why it is important? Because if you have a person in pericardial effusion This is another view, subcostal view, where you could see the heart floating. Heart is just floating within the pericardium. It's mobile, but it's not generating enough cardiac output, and hence patient would be in severe hemodynamic compromise. A word about cardiac output. Though it seems very difficult, but mark my word, it would be very easy thing to have an echocardiography probe and tell about the cardiac output. Not the static part of it, rather the dynamic part, which is, I have mentioned earlier about VTI. VTI is velocity time integral, where you try to look at heart, acquire a good parasternal long axis view, zoom to the LVOT, and then have a measurement of the LVOT. Since it's a cylinder, you know the area would be a pi r square h. Since we have acquired diameter, it would be diameter square by 4. And hence, you could come to know about area. Second thing is acquire a 4-chamber view, flatten your probe to acquire the 5th chamber, that is opening of aorta, run continuous wave Doppler through it, sample in LVOT, and you'll get this image, a triangle, reverse triangle coming into your image. Just freeze the image and move the cursor and take a measurement. This measurement is VTI. Normally, it is between 18 to 22 centimeters. So if you have a VTI less than 18 centimeter, your cardiac output is less. If it is more than 22, it is hyperdynamic. So with this, in a patient where you know the aortic dimensions are not going to change much, you can skip the earlier part and directly have LVOT VTI to your frame and just tell about the cardiac output. If you see lots of variation during inspiration and expiration between the VTI curves, you could simply make out that this particular person may be fluid responsive. The only thing you need to know is what is the preload. A word about RVSP, that is right ventricular systolic pressure. Acquire a 4-chamber apical view, then sample at the tricuspid area. What you get is a tricuspid jet. Just measure the maximum velocity. In this case, particularly, it is 2.28 meters per second or 228 centimeters per second. So use Bernoulli's equation, square it, 2.2 square would be 4 point something, and then multiplied by 4. 4V square is the Bernoulli's formula. So that would be 16 centimeter. Now you need to assess your IVC at the same time, and basis the IVC size, you could have RA pressure estimation, where if your IVC size is less than 17 and the collapsibility of respiratory variation is more than 15%, then it would be the RA pressure of 5. Similarly, if your IVC size of more than 17, basis the collapsibility, if it is more than 50, the RA pressure estimate would be 10. If it is less than 50%, the RA pressure would be 15. And if there is no collapse, the RA pressure equivalent would be 20. So simply add RA pressure by this IVC measurement and with RVSP by acquiring an image and getting a jet and measuring the maximum velocity gradient. So you could have a good estimate with this. This is a summing up slide where you are shown all the views I could say that I have talked everything about it. So now moving to the last part of my presentation, wherein I have used this article, which is a review article from Trazadel, Germany. It's a recent one where they have tried to have reviewed all high-risk patients, and they are focusing on focused hemodynamic assessment rather than an echocardiography. What they say is what an anesthesiologist need is manage the hemodynamics. So, and they have shown in their study that it needs only 2 hours of practice, and even a novice can acquire a good image. The next part, that is analysis of those acquired image, still takes further time, but if an image is acquired, probably you are half done. So I'll be skipping and moving to what they have talked about in their article. They have 6 steps. The first of the step is about cardiac filling impairment, where they try to look at pericardial effusion. And if you could see, this is an image where this is pericardial effusion. They have marked it here with this. So if you could see this, you could simply make out the obstructive shock patient and label, and can manage even further by therapeutics under USG or EchoGuard. Moving to the second part of the steps of the hemodynamic assessment, you need to know about the volume status and the responsiveness. So how to get it? If you could acquire this view, that is parasternal short axis, what you could see is concentric LV with papillary muscles. So this is labeled out here. The only thing, if you have a kissing papillary where the 2 papillary muscles are close together in systole, probably you are hypovolemic. The only caveat is, before telling this will be a collapsing or a papillary kissing papillary, you need to look at the interventricular septum and its thickness. If it is LVH, then probably this analysis, which you are just telling on the visual gestalt rather than any measurement. So you need to take this caveat into your account while telling it. This is one of the qualitative way of talking about hypovolemia. The same thing in systole. Now, to tell about volume responsiveness, the presentation would be incomplete if I don't talk of IVC and its collapsibility index. Collapsibility index is just a measure of the changes in diameter of IVC during inspiration and expiration. It is valid both for spontaneously breathing patient as well as mechanically ventilated patient. But the collapsibility and distensibility index are different. For collapsibility index, for spontaneously breathing patient, it is more than 50%. And for ventilated patient, it is about 18%, 18. So what you need to do is acquire a subcostal window, put a M mode out here, and what you will see is M mode picture. Then you just measure the maximum and the minimum diameter, and the difference between 2 being numerator and the minimum being the denominator. What you acquire is a collapsibility index. Or distensibility index is the same when your patient is on mechanical ventilator. This slide is just telling how to interpret your collapsibility index. For example, if you have a subcostal IVC, and if you could see it, visualize, and there is no variation in respiratory variation in IVC, you could say the filling pressure is too high and you need to stop fluid. Similarly, if you have IVC where it is collapsed and there is marked variation in respiratory phasic variation, probably filling pressure is less and then you need to give more of a fluid. And if something is in between, then probably you need to use passive leg raise test, as I have mentioned the procedure, or a fluid challenge or a mini fluid challenge to better understand what's going on. So the other thing is the contractility of RV as well as LV. Beginning with RV, you could simply acquire a 4-chamber view. This is a subcostal view, and then just move your cursor and mark it and see the measurements. Usually, RV should be 0.6 times the LV. LV should be the biggest. But if the index, RV to LV index, what we say, if it is 1, probably your RV size is bigger. And what do you mean by bigger RV size is the hemodynamics will be severely compromised and the blood is not going to go to LV because of interventricular interdependence. And probably you need to do something for your RV. The other way to look at the same would be by putting your M mode cursor over the tricuspid annulus and acquiring an M mode image where you need to measure this systolic excursion. This is called as TAPC, that is tricuspid annular plane systolic excursion. If it is more than 17 millimeter, then your RV function is okay. So if it is less, then is a warning sign. So moving ahead.
5 minutes, Dr. Kumar.
Okay. Yeah. Yes. Then you need to have some measure of your valve. If you could acquire a good image and put Doppler and see the flows or the turbulences with the help of Doppler, probably you could make out that, yes, this is a very vena contracta, widened vena contracta, and you could say about this. Otherwise, morphologically, when you acquire an image, you just have to look at the valves, the thinness, the leaflets, the closing of the valve, and coaptation defect if it is there. If you could visualize, then you need to take care from those. And the last is rating cardiac output. As I have mentioned, cardiac output is simply you just go ahead and do the VTI, acquire a 5-chamber view, and just put the CW wave at the aortic or LV outlet track, outflow track, acquire an image, and then this will tell you about what is the VTI. In this case, it is 27.2, which is higher or suggestive of hyperdynamic circulation. If you have such things, you need to look at the preload as well. So in this way, if you have some idea about acquiring a good image and interpreting on, if you practice, then probably it is easier than even a stethoscope. So with this, I would like to end my presentation and will be open to questions. Thank you.
So I have a question for you, please, sir.
Yeah.
What are the indications of asking or requesting a pre-op echo for the patients? Usually, what are the usual indications? What's the latest guidelines? When to request an echo? This is a big problem happening in most of the hospital, the struggle between surgeons and anesthetists that we need echo, they don't want echo. So how do you recommend our junior doctors when to request an echo?
Definitely. See, whenever there is something which is beyond like a valvular defect or a congenital heart disease or something where you have screened and seen that there is something which is beyond my learning, then probably is the time to rely or ask for echocardiography from our side, being an anesthesiologist. Majority of the time, it would be the echo has been done for you. And that doesn't help us. That doesn't help us in a way because the echo, if you look at 3 components, the components of echocardiography are preload, afterload, and contractile function. So if someone is mentioning a contractile function, okay, then we need to look at the simultaneously what is the preload and afterload. So when we are getting a patient and we are trying to just have a visual gestalt, then probably what you are looking is the contractility, afterload and preload at this particular point of time. So many a times when you have a patient who is ejection fraction 40% or 35 to 40%, and they came to you, then what we are facing the dilemma is, because we don't know at what preload and afterload this ejection was there. So probably when my patient after anesthesia, after induction of it, the BP falls, what would you do? Because if you don't have the baseline echo by your own, then you couldn't say that LV dimension pre-op was this much. For example, a DCMP patient with a LV dimension size of 65 millimeter. And now you have diurise and now getting into operative theater. And before induction, if you do it again, and it is about now 55. So the dimension has decreased by 10 centimeter. That means if my patient is going into hypotension and have some decrease in cardiac output, to increase the cardiac output, you need to even give fluid, because your chambers have collapsed because of diuretics, negative fluid balance. So it is not to use noradrenaline upfront, because that may increase the LV outlet obstruction because of hyperdynamicity. So echocardiography for anesthesiologist is a must. And it shouldn't be called as echocardiography, rather it should be focused hemodynamic assessment. That's it.
Very good. Thank you so much, sir. This is a very true answer. So it's not a must for everyone to request a cardiologist to come and perform the echo. It would be much better if an experienced anesthesiologist check the echo for the reasons that you have mentioned, to check the three components: preload, afterload, and contractility. Thank you, sir. Dr. Wissam. So I think any other questions, Dr. Wissam? No other questions. So we conclude our first session. Thank you, sir, so much. It has been a pleasure to listen to your lecture. And I think we should.
I have a question.
Yes,
okay.
Sir.
Yeah, I yes, have sir. A question for Dr. Kumar.
Yes, sir.
If you please. Is there any, in the mechanically ventilated patient, how to use, or is there any rule of echo to optimize the beep, for example, or to manage this problem with the patient hemodynamically?
Okay. My answer would be, for a patient who is mechanically ventilated, the better tool would be transesophageal echocardiography, TEE. But if you could not, then you need to go with transthoracic echocardiography. And the best view available would be the subcostal view, where you could just insinuate your probe to the subxiphoid portion and acquire all the four chambers. And this would be the tool to go for every time you have a patient, because this is the easiest view where everyone can insinuate your probe through liver. Liver being a very good acoustic window, you acquire more often than not, you'll acquire a good image and have some pathology. If it is there, you could have a good look.
Okay, sir.
So
thank you. We have another.
Yes.
We have another short question. It's coming from Dr. Shaban in the question and answers. He's asking, what is the correlation between ejection fraction area done by TEE and the real ejection fraction of the patient?
I really don't know what the question is.
He is asking, I think he means that is the TEE ejection fraction estimated, TEE estimated ejection fraction done, is it the real ejection fraction of the patient, is it very accurate, or how accurate is it?
Both are accurate enough. The only problem is the view. If you could get a good view in transthoracic echocardiography, the accuracy of ejection fraction or fractional shortening would be the same. But,
yes, sir.
But the problem is many a times you couldn't get a good view, and then is the time to switch or look at the other modality. So it is like if you are acquiring a good image acquisition in itself is increasing the specificity of everything. But at times you couldn't get it, and then you need to go for more than 2 views. One view is not enough. So you try to look at it from different angles and then comment.
So for the last question, because we are out of time, way out of time, it's a very short question, and I think its answer is a simple yes or no from Dr. Muhammad. He's asking, is age an indication to do an echo, especially elderly patients above 65 years of age? And
No.
the nod on your head, it says no. So this is not an indication. Thank you, Dr. Muhammad. I think by this we can conclude our excellent first presentation for today.